Coping with teen angst in a complex iWorld. This is part 3 of a 4-part slide program available on YouTube. Chapter 2, Pediatric Pharmaceutical Suicide Risk. Emergency department visits for suicide attempt and self-injury increased by 47% in the last 10 years. This data comes from Greg Larkin, a researcher down in New Haven who has been studying psychobehavioral trends for many years. Now this is an actual screen image from an iPod that has malfunctioned. We're using our iPod metaphor again to highlight key points. All forms of technology result in occasional hiccups like this one. Sometimes a simple reboot is needed. In other cases, an upgrade to a brand new model is required. But doing so is not so simple when suicide is the complication. Here's a graphic demonstrating a gradual decline in suicides since the early 1990s. These are completed suicides. This will be relevant a little later, but it is important to note that better recognition of illness and better overall therapy are likely responsible for this favorable trend. But why has this issue of suicide become so newsworthy now, especially since these trends look so favorable? Well, before this millennium, most psychotropics were used in children off-label. What was known in adults was extrapolated to children using a best guess approach. There was little incentive for pharmaceutical companies to study these medications in children, and enrolling minors is complicated, as anyone who has filled out a BMC IRB form knows. The FDA Modernization Act of 1997, signed into law by President Clinton, is the reason why we now have data on suicide risk in children. This was a complicated law with many components. Two components of the Modernization Act are relevant to our talk today. First, the Act relaxed the ban on direct-to-consumer marketing by pharmaceutical companies, so now they can advertise during NASCAR races and anywhere else directly to the patient. Second, and more importantly, the Act provided for 6-month exclusive drug patent extensions to pharmaceutical companies who systematically studied their medications in children. Now, whether or not the drug was deemed effective was not a requirement to qualify for the extension, simply that data on children needed to be collected and presented. Now, 6 months does not sound like a long time, but let's consider the example of Paxil. In 2002, GlaxoSmithKline, the makers of Paxil, reported $3.3 billion in annual sales of Paxil. So another 6 months of exclusivity is a lot of money. So what happened? Well, GlaxoSmithKline reported data to the FDA in 2003 while preparing an application for a patent extension by showing they had done the requisite pediatric studies. They provided data suggesting an increased risk of suicidal behavior by pediatric patients in their study when compared with placebo. At about the same time, British healthcare authorities issued a warning that antidepressants were associated with pediatric suicidal behavior. Now in Britain, medicine is socialized and they have better population-based databases that allow surveillance of specific populations when it comes to prescriptions and hospital and outpatient visits. So based on GlaxoSmithKline's data and the British Healthcare Authority's warning, the FDA requested pediatric data from the other manufacturers who were conducting studies on antidepressants in children, and the FDA conducted its own investigation. Now, the FDA's final report is available online. It is a complicated, long document, and the investigation itself is complicated because it included 24 studies, 4,500 pediatric patients, and most importantly, suicide was not an outcome in any of these manufacturer studies. It was instead documented inconsistently in adverse event reports. In some cases, suicidal behavior was coded as emotional lability. So a team of 10 suicidologists from Columbia examined every single one of those cases to determine which qualified as suicidal behavior and which did not. Now, we all know the end of that story. A black box warning was issued based on the FDA's findings. If you're interested in reading an abbreviated version of the same FDA report, it was published 2 years later. It is right here, and the lead author is the same as the lead on the FDA report. The numbers to know are these. For every 100 subjects receiving the study drug, 3.8 exhibited suicidal behavior, whereas only 2.1 of those receiving placebo exhibited suicidal behavior. Thus, this was deemed a modest risk and reason enough for the black box warning. Now, of course, because of so many invested interests with incompatible priorities, the critics lashed out and argued that the report overestimated risk and underestimated benefit. They argued there were no completed suicides in the analysis, which is true, but it is also important to know that children considered to have any risk for suicide were excluded from the studies to begin with. The critics also argued that off-label use of SSRIs contributed to the steady decline in suicides over the years, which may or may not be true since other interventions were incorporated at about the same time. The critics also argue that suicidal behavior is a normal, expected feature in all patients started on antidepressant therapy and that close observation is needed in all cases. This behavior is termed activation and has been cited in old textbooks and a recent study that suggests activation occurs in all who are started on an antidepressant regardless of age. Importantly, all those pediatric studies lasted anywhere from 4 to 16 weeks, so they were all only short-term studies. Many conflicting papers were published shortly thereafter. Gibbons published a study suggesting that the black box warning reduces the rate of written prescriptions and therefore increases the rate of completed suicides. This was based on prescriptions written in various counties. It required a lot of assumptions by the authors. Unfortunately, he did not acknowledge in this article how he was an expert for the makers of Effexor during the FDA proceedings. A case control study by Olafson, published at the same time, looked at a more homogeneous sample than the FDA's subject pool and demonstrated an increased risk of completed suicides in those taking antidepressants. This paper contrasted with Gibbons. What was lost in all this discussion was what, if any, benefit did these antidepressants have in the treatment of pediatric psychiatric illness? A study by Bridge from 2 years ago tried to answer that by looking at risk and benefit. They examined the same studies the FDA did and added a few more, and in the end determined that depending on the drug and the indication, the number needed to treat ranged from 3 to 10 and the number needed to harm ranged from 112 to 200. Now, in the discussion of that paper, they raised the important question: does any level of risk justify the use of these medicines in younger populations? Well, the FDA asked the exact same question, and after a more comprehensive study, including many, many more subjects, they expanded the black box warning up to the age of 24. Now that's a significant chunk of the pharmaceutical industry's market share. What convinced the FDA was this graphic right here. See the trend? Even using different statistical methodologies and different analytical techniques, this trend remained essentially the same in their analysis. Perhaps younger or less mature brains are not fit for SSRIs. I'm not sure we have a conclusive answer right now, but here are some thoughts. First, many have suggested that these medicines really need to be prescribed differently, not just in lower doses from adults, but in different frequency in the pediatric population because of developmental pharmacokinetic differences. It is not my purpose to go through those differences. These should be familiar to many in the audience. Metabolism and elimination of xenobiotics changes as we age. For a comprehensive read on these developmental differences, see an entire supplemental issue of Pediatrics from 2004 that explores these questions. Could there be a pharmacogenomic risk? We all know some patients clearly improve and some clearly get worse. Could polymorphism explain how these drugs work differently in different people? A few papers in the last few years argue this to be true. They all have complicated titles like this one on the screen. Are patients who we can't do genetic bedside on going to get better or worse if we prescribe a new antidepressant to them? Well, at this time we still don't know because we can't do bedside genetic testing. But this 2009 in-press paper, it's available online, it hasn't been published on a printed piece of paper yet, is a nice examination of this very issue. This is an evolving question, and we will have a lot more data in the next few years. This is an area where bench to bedside will help answer some important questions. What about polypharmacy? This study from Brazil was published 2 years ago. It's not a great study, but they ask an important question. Are patients who are on multiple medications, all competing for the same neurotransmitters, at higher risk for suicidal behavior? Now, they tried to control for severity of depression, and what they found was The more medications a patient is on, the higher likelihood there is for suicidal behavior. Remember how we talked about polypharmacy earlier in this talk? This is a terrific question that requires further study. This question of suicidal behavior prompted by psychotropic medications will continue evolving over the next few years, and we really need to watch the data as it unfolds.